to read this report and that we can discuss it in Spanish. So with that, I'm going to share my screen, and we're going to start with, if I can find it. Yes. And we're going to start with Juan. Give me 1 second, please. Okay, I cannot see you, but I'm assuming right now this is full screen. If it's not, please let me know. And with that, we're going to move to Peru, and Juan, over to you.
Thanks, Paul, for the presentation, and I am pleased to be here with some colleagues in this project. No, well, Peru has been the country that received the second largest number of Venezuelan migrants. According to the National Superintendence of Migration, as of June 2021, there were 1,200,000 Venezuelans residing in Peru. No, now they are more. No, the entities specialized in migrations calculates they are 1,400,000 of Venezuelan in Peru, no? But in regular condition. No? We don't know how many are illegal now. No? Peru has historically been a country of immigrants rather than immigrants. It is estimated that from 1990 to 2020, 3,300,000 Peruvians have emigrated. No? These figures shows that Peru has entered a transition to an increasingly transit and destination country. The migration phenomenon has meant a significant change in the plurinational composition of Peruvian society. No? Please, the next slides. The next migration in Peru is divided in 3 main stages. No? The first open door policy from 2017 to mid-2018. No? The second one policy was of criminalization of the migrant from mid-2018 to 2019. And the third one was the policy of invisibilization of the migrant from 2019 onwards. No? The first stage of Peruvian migration policy created conditions that attracted a number of migrants, but their admission to that territory did not translate into real integration into the formal economy and public services. The table of Venezuelan health insured accounts for this, although the gap has been closing slightly. The EMPOVE, that is the National Survey on Venezuelan population of the year 2018, showed 91% of Venezuelans not affiliated to any provider. The same survey in the year 2022 shows 18% affiliated to the public insurance. The name of the public insurance is CIS here in Peru. No? This is because conditions were created for any citizens who does not have other health insurance to obtain it, although in a regular condition. No? The following stage were marked by measures based on stigmas, prejudices, and stereotypes. Thus, there was a change in attitudes toward migrants. The national survey, the last one, shows that the main reason for discrimination is nationality, followed by race and way of speaking. No? You can see in the figure that the majority of migrant entrants enter by the entrance gate of Tumbes in north of Peru, and they exit to Chile by the region of Tacna, no? In Lima, we have 90% of the Venezuelan population. No, they come to Lima, especially to Lima. No, the next, please. The Peruvian health system is organized in a fragmented manner by provider entities aimed at different target audience without coordination. No? We have the MINSA and Integral Health Insurance, or SIS, for the poorest, Social Security, Salud, for insured workers, and private EPS for insured workers in the public sector, and the insurance EPS and clinics for the upper middle classes. No, we have a fragmented system, no, health system. No, Peru public spending on health is 3.2% of GDP. No, in 2017, Peru was below the average of public spending on health in the region, that is 6%. No, as a result of major deficiencies in terms of human resources, infrastructure, and budget, the Peruvian health system was already characterized by a significant gap between the demand met and the met needs. In short, it was not a strong health system that received a migrant, but one that could not attend to its national population. No? The next, please. This table shows an increase in the number of patients attended, no, in the period from 2007 to 2021, no? And we can see the potential demand grow, no? But also, no, the majority of this demand is going now to pharmacies. You can see the column of pharmacies. No, they were 30% in the first year of this series, and they finish with 22%. No, we don't see the same phenomenon in MINSA, our Ministry of Health, and in our social security system, that is Salud. No, MINSA begin with 60%, no, and finish with 70% in 2018. No, before the pandemic. No, and Salud is the same case. No, so the conclusion is that the demand is going to the informal sector in our country. No, is in a special trend, is one model of transformation in a poor country without a big public spend in health. No, the next, please. Which are the barriers? No, the reduced access to the health system experienced by Venezuelan migrants can be categorized according to 4 types of barriers. No, economic, legal, cultural, and information. No, the economic barrier is closely related and mutually reinforcing with the lack of access to healthcare. Low income, instability, and lack of labor rights make the economic barrier to accessing the healthcare system considerably high. No? The legal barrier is related to the mandatory procedures to obtain health insurance. For example, access to Social Security requires a formal job which excludes most Venezuelans. No? We can see in the table the reasons that have the Venezuelan migrant for not attending a health center or facility, no? The evolution in these 4 years, no? And the table for both periods shows that among the main reasons why the migrants did not go to a health center or facility are because they didn't have maybe a serious problem, but they don't have money and don't have insurance. That are the 2 reasons, no? The central reason. The cultural barrier is related to the discrimination experienced by Venezuelan migrants in society in general and in health facilities, no? The information asymmetry is closely related to the lack of knowledge of migrants for access to health services and in general the exercise of their rights, no? It is also the lack of knowledge of health personnel about updates in regulation related to the migrant population, no? The next, please. Here we have some facilitators, no? The general law, health law, states that everyone has a right to free access to health benefits and to choose the social security system of their choice, no? This regulation stipulates that the right to the public health system is independent of migratory status, no? We have different availability of information on migrants is scarce and fragmented, no? Except for the 2 national surveys that we have, no? And that led us to see the evolution of the profile of the migrants, no? The next, please. No? We have problems with the documentation policy for migrants, no? Because our documentation for migrants, we have had an evolution, no? Peru is a pioneer on the provisional identity document for migrants. The temporary permit to stay created in January 2017 allowed migrants to enter to the country and enter the labor market. But in June 2019, the entry of migrants would be conditioned by visa and passport, which were very difficult to obtain due to their high cost. No? In the 3rd stage, with the onset of the pandemic and the mandatory social immobilization, the superintendence of migration was prevented for granting migratory documents, no? And this was a big barrier for the migrants, no? And after, in the 4th stage in July 2020, the first measure was taken that could signal the beginning of a new stage in which bureaucratic procedures would be digitalized, demonstrating a strategy oriented to the medium and long term, no? That's the evolution of the documentation policy for migrants that affect the access of the Venezuelan population to the facilities of health, no? The next, please. This is the explanation I was trying to speak about, no? When we have had the quarantine in March of 2020, border closure post policy, we in Peru didn't have any special regulations for Venezuelan migrants that were trying to have an integration in the economy and in the Peruvian society, no? They suffer more, no, than the national population, no? And this was a collateral incentive to illegalization. Now we We have studied the three first stage of the migration policy in Peru, but we are studying the next, that is the actual stage, and we think we are probably with many migrants in illegal condition. The next, please. Bueno, we have had a special policy about human resources because one of the health policies in which the Peruvian state seemed to be most concerned with the inclusion of migrants in terms of the number of regulation, but was the provision of medical personnel for the health system. No? How you know, Peru suffered too much in the pandemics, no? And Peru urgently needed health professionals. In April, no, 2020, the special COVID service was created. If through this provision, national and foreign medical personnel were hired and they under a special arrangement due to the lack of medical personnel in the midst of the COVID crisis. No, the agents involved in the response have been of three types in our case. Decision makers, no, including the presidency, the prime minister, the foreign ministry, and the Congress. No, in second place, we have the promoters, made up of cooperation agencies and humanitarian aid organizations who were fundamental for the regional response to the migrant situation. And third, a state service provider made up of some ministries, including the Ministry of Health. This differentiation is important because the decision-making were the little circle that decided the policy on this subject. That is all, I think, Paul. Thanks.
So, can I go ahead?
Sorry, I was on mute and I was speaking. I apologize. Thank you very much, Juan, and it's over to you. Sorry about that.
Thank you, Paul. So I'm going to present the case of Mexico, and I think it's very interesting because there are many parallels in terms of the health system in Mexico to what Juan was just presenting. And at the same time, there are interesting differences in terms of the types of migrant populations that we are addressing, or the main issue in Mexico right now. So please, next slide, please. Thank you. So first, I'm going to talk a little bit about the migration context in Mexico. The first thing to know is that Mexico is the second main country of origin for international migrants. So the second main sending country after India worldwide. So we have a long-term, decades old, or maybe 100 or over 100 years old tradition of migration from Mexico to the US, especially. And this migratory tradition includes people moving from Mexico to the US, but also return migration and people who is of Mexican origin and has been born in the US and coming back to Mexico to receive. So that's the main migration phenomenon in terms of numbers in Mexico. At the same time, we have had in the recent years an increase of different flows that I'm calling in transit with question marks, because these mixed flows are mainly composed of people moving across Mexico because they want to reach the United States, but they are not succeeding very well. So in many cases, they are staying in Mexico for longer and longer periods, and some of them are even thinking of Mexico as the place they want to stay in for a long time. So this has changed the migration panorama in Mexico a lot in the past maybe 2 or 3 decades, and especially in the last 10 years, since we have seen this increase in the number of persons moving because of reasons, not just economic reasons, but also displaced by violence or climate-related phenomenon, etc. In the graph to the right, I wanted just to show the yearly asylum claims in Mexico from 2013 to 2021, and you can see how it has increased a lot. It's still very low in as compared with the numbers of, for example, Venezuelans coming to Peru or Colombia, but it's still a very important increase and something that has challenged Mexico's policies, and especially the healthcare system. Yeah, next slide, please. Thank you. So in terms of the healthcare system, this is very similar to what Juan was describing for Peru. We have a fragmented health system that is composed of public and private elements, and the public sector is composed in turn of 2 main systems. One is social security, which is related to work, and you are required to have a regular employment in order to access that system of social security. And then we have a public system that is open to anyone, but it's traditionally it has been targeted or covering the needs of the people of lower income and who has no regular employment. So this type of system that is coordinated and managed by the Ministry of Health is the system that covers most in-transit migrants. And I'm going to focus in these in-transit migrants, and I'm going to call them in-transit, even if, as I said, they are staying in Mexico for longer periods of time, because they are the ones that has been in the public eye as a humanitarian crisis. People coming, as I said, from Central America especially, but also from other countries in Latin America and the Caribbean, and even in other continents. And as they are not being really integrated or included in the Mexican system of social security, most of them have to resort to the, or will need to resort to the coverage, health coverage provided by the Ministry of Health. Now, there is also a private sector, and as in the case of Peru, pharmacies are becoming very important in that private sector, because pharmacies provide care which is relatively cheap, relatively non-expensive, and it's also easy to access. So many people access that type of services, but at the same time, it's important to notice that those services are not very good quality, and they don't provide preventive care. There is no continuity of care. There is not a single provider or general provider of care. So it's not the ideal, it's far from ideal, but it is, in fact, what is covering 20% of the population, at least for ambulatory care. So it's very important. On the other hand, and especially for migrants, international organizations and community service organizations are very important. It was civil society organizations. I don't know why it's well, civil society organizations, CSOs or ONGs, which are providing most care for migrants. Even if, according to the law, all persons in Mexico without social security have the right to receive healthcare at no cost. Next slide. So in terms of the barriers and facilitators to access healthcare for migrants in Mexico, well, the main barrier, I think, is, as I was saying, the limited access to social security because of limited social inclusion. So I would say that the main barrier to access healthcare is lack of social inclusion, lack or limited policies for social inclusion. In the past, maybe 2 or 3 years, and probably or partly in response to the COVID crisis, international agencies and the Mexican government have engaged in some programs to facilitate access to employment, to regular employment for migrants, but this is still covering only a small percentage of them. So we still have this situation in which most migrants, especially migrants in transit through Mexico, non-Mexican migrants, are not really able to access social security, and therefore are not able to access regular healthcare as covered by social security. This results in that people have to pay out of pocket for most care. So there is a huge economic barrier to access care. In surveys of the in-transit migrant population, this is the main barrier that is mentioned, the economic barriers. And then the third main barrier is limited information on rights and how to access care on the part of migrants. So even if the law says that migrants can access care free of charge and freely in the system, in the healthcare system operated by the Ministry of Health, migrants have limited information about that. And even when they access those services, still there are some providers that don't know that they should provide that service. So that still constitutes an important barrier. On the other hand, the facilitators, as I said, the main facilitator are civil society organizations who are helping migrants to navigate the system, who provide advocacy and even help directly provide healthcare. And this is what is helping most migrants to cover their healthcare needs while they are in Mexico. The other, as I was saying, is that the awareness of in-transit mixed flows as a humanitarian crisis has increased in the past years. So that has meant that the Mexican government, but also international agencies, have been putting in place different actions, different initiatives in order to facilitate access to healthcare or other social care aspects. So that has been a facilitator of access to healthcare. During the COVID-19 pandemic, concerns about transmission made the Mexican government, the Mexican Ministry of Health, develop a plan to attend to the health care needs of migrants. This plan was important because it put migrants in transit probably in the eye of the public health system, but at the same time it was completely focused on COVID-19. So it was mostly a plan of epidemiologic surveillance and response, more than a plan for comprehensive health coverage. And the other thing is this legislation that mandates free access for all, which has been evolving in the past 2 years. And it has been more inclusive of migrants little by little. So it's now it now mandates that all migrants should be able to access healthcare free of charge, as I say. That's in the legislation. That's not completely implemented, so that is still an important barrier. Next slide, please. So to summarize, about the healthcare response of the Mexican system during COVID-19. First of all, there was this plan developed by the Ministry of Health, which facilitated epidemiological surveillance and epidemiological response. And what this plan was focused in migrant shelters. These migrant shelters are shelters mainly operated and supported by civil society organizations, some of them faith-based organizations, some not, that traditionally have provided shelter, of course, shelter, food, and other services for migrants. And during the pandemic, the strategy of the Mexican government was to collaborate with these organizations and to go to the shelters and provide the tests and trying to detect outbreaks of COVID in those places. At the same time, what really happened was that even with this plan in place, there were no resources allocated for this response. So the local level of the health ministry, the local level of the public health agencies had to respond to this situation in the migrant shelters with the same resources they already had for covering the local population or the non-migrant population. So even if this was a strategy targeted to migrants, it lacked the means to be put in place. It worked, as I said, because it put the situation in the eye of the local health departments, but it wasn't really effective in terms of providing resources to care for the needs of migrants. The other important strategy was developed mainly by the civil society organizations, and it was a response that advocated for alternatives to detention. In Mexico, we have the migrant detention centers, which the National Migration Institute operates. And of course, those were places of high risk of transmission of COVID during the pandemic. So a number of civil society organizations pushed for alternatives for the closure of these centers and alternatives to detention. And this led to the closing of some of those facilities. In other places, they kept working during the pandemic. And there were many different local solutions to the administrative barriers for vaccination. And this was very interesting because there was never a rule or a norm that excluded explicitly migrants from vaccination, but at the same time, some documents were required to register and to receive vaccines that migrants wouldn't have. So many local solutions were put in place for this, and they were different probably in each place. And the agents who pushed for these solutions were, again, civil society organizations and the local levels of the ministries of health. So I think the local level was very important in this regard. And as for the agencies involved in the response, again, I think we need to recognize that civil society organizations were the main respondents in this situation. Then there was the international agencies, the UN-related agencies especially, and international NGOs. I'm giving just 2 examples, but there were many others. And at the same time, the federal, state, and especially local levels of the government, and especially the local levels of the Ministry of Health, that came up with innovative solutions to facilitate access to care for migrants during the pandemic. And with this, I conclude. Thank you. Over to you, Paul.
Thank you very much, Aitza. Very, very interesting. We're now going to go to Andres to discuss Colombia. So over to you, Andres.
Thank you very much, Paul, for this invitation. I will share with you some of the main important aspects in our outcomes in the study. In the case of Colombia, we share some of the information that my colleagues presented before in Peru and Mexico. And I think that the most important thing is that we share some of the realities of Latin America. And first of all, is that in the process of migration, we have a push model between the 16th, 17th, 18th, and 19th, that many people from Colombia were expelled from our country, and some of them live abroad of the country here. And in this moment, starting from 2014, the main migration to our country is in the process of migration from Venezuela. We are the first country that received this population from Venezuela, not only because we share a border, we share a territory, it's because in the process of migration in Colombia, we have a very specific situation that in this process, in the start of the process of migration from Venezuela, many of the strategies that were implemented in the region here in Colombia, we opened our borders to receive many of this population. The first thing that I wanted to share with you is not only that we have a Venezuelan population here in Colombia, we have also Colombian returnees from Venezuela. In the graphic that I'm sharing with you, all this evolution of the migration include the people who were coming from Venezuela with a Colombian population, mixed families who were Colombian and Venezuelan population, and also in transnational indigenous people. This is not only the Venezuelan population who were coming from, and that is very important, and it shows the close relation that we have in our historical movement from Colombia to Venezuela, and now from Venezuela to Colombia. And it is the most important thing that we can share all this information. In the first process of migration from Venezuela, we have different people who were coming in the first part. When you see the first part of the draft, from 2014 until 2016, the process of migration were included mostly of them Colombian people. This was because the national government from Venezuela expelled most of the population, Colombian population. It was a strategy for the national government. In the second part of the draft, you can see the Venezuelan people who were coming really in this process of migration. In this context, we received different to other context of migration from Venezuela I'm talking about the people who were going outside from Venezuela to the States or to Europe, who were rich population or wealthy population. We received many of the vulnerable population, and this is a very important aspect for all the region in the process of migration. Because many of the people who were coming from Venezuela, they need access to the system of health, they need access to the education, and they need access to all the social policies that the Venezuelan government, because of the collapse of the state, they couldn't continue in this response to their own population. That is why in the first part of this migration, we have humanitarian response. And but in this moment and after COVID, we have international cooperation in this response that changed the model of the humanitarian cooperation. And it was very important in the first part of the process, because our system of health couldn't respond to all the people from who were coming from Venezuela and what they really need. And that is why in this context of the COVID situation, the Colombian government was thinking about that in the process of the COVID situation, the people who were coming from Venezuela were decreased, and as the graphic shows you, it leveled the level of the migration process decreased, but not in the numbers that the Colombian people who were thinking about. And after the COVID situation, when we open all the borders, they continue increasing. Currently, we have more than 2.4 million people who are coming from Venezuela, and why they are coming from Venezuela in this current situation, because they need to the response of the system of health. That is why this study, what we are doing with Peru and Mexico, it is important. That is the most important thing, why we are trying to understand why these people are coming from, is because the system of health is the response of our system of health in Peru and Colombia try to respond all that these people need in this situation. Next slide, please. Thank you. And as Yetza shows you on one, in Colombia is the same. We have a fragmented health system. In our system, we have this mixed system with a public system of health and a private system of health. And in this process of affiliation of the people who were coming from Venezuela, most of the people who were Venezuelan people were vulnerable people, and they live in a poor situation. That this increased in the COVID situation. That is why our system of health tried to have a specific response with different mechanisms, and including international cooperation, non-profit organizations, our local system of health with the secretaries of health in the border regions, to try to have a better response in this humanitarian situation. And in this context, many of the cities who were located in the border before this process of migration, we had a specific response to maybe 8,000 or 10,000 population who were living in the border. But now we need to respond for more than 300,000 people who are located in these different cities. That is a situation that affect the system of health, and it could collapse our system of health. And because many of the people who were coming from Venezuela, they have access to the emergency services, and they don't have access to the system of health in the regulatory situation. That is why is this situation presented, is because in our legislation, the people who are non-citizen here in Colombia need to have a regulatory situation and to be migrants. When they are migrants in this irregular situation, they don't have the access to this all our system of health, and the affiliation of the system of health is very difficult, and they don't have all the access to the services that they need. The door to access to our system of health is the emergency services. And if you see all the information who are accessing to our system of health, the majority of this population are women, pregnant women, and people, children who needs to this first access to the system of care. And that is why our system of care have this, is in this specific situation, we have very limited access to the health system services and medicines, because many of the people try to access to our emergency services. And some of the people try to access to the insurance in the private service, but is according to our data, only the 15% of the migrant population, they really access to the private system. And that is a very important trouble that we have with to try have a better response to the people who are coming from Venezuela. During this process of migration, we have an impact not only in physical situation, because the majority of the people who are coming from Venezuela, they cross the border by walking, and they have many risks because they continue walking inside of the country, and they don't have a specific transport to go to access to to Colombia. And when they try to move to our capital cities, they continue walking. And it's because of this situation that many of the institutions or NGOs institutions are very important to give them the first attendance in the health system. And many of the studies that we have done in this process of migration shows that the main impact of this process of migration is in the mental health for the migrant population, because they don't have access to jobs, to regular jobs. They don't have access to quality of life that they need to continue in their quality of life in this process of migration. And the impact is because they suffer violence, xenophobia, and many of the persecution that the process of migration are presented in this movement from Venezuela to try to access to other cities to have a better response, as Bogota, for example, or Medellin or Barranquilla. But to try to access to the system of health, they have many barriers to access to our system. Next slide, please. Which barriers are presented? The main barriers is the migratory status, as I told you before. Many of the decrees, policies, plans, and programs who were involved in the response of this process of migration, as in Peru and in Mexico, the migratory status is very important to have a better access to the system of health, and because they don't have this status in the process of migration. We have different strategies to have a better status in our process of migration. First of all, is the permiso especial de permanencia. This is a permission that give to the people access to jobs, access to system of health, and access to some social policies to have a better response in this process of migration for the health system of care. But many of the people, they do have access to the migratory status, and only 64% of this population have access to this migratory status. But all the other people who don't have access to the migratory status, they don't only have many barriers to access to the system of care, also they have this pocket, out of pocket is expensive. That is why many of the people who were coming from Venezuela, they couldn't have access to the primary health care or the treatments that they need in this process of migration. If we have a very important system of information that try to know who are coming from Venezuela, what they need, where they are going in this process of migration, and where are they located. But during the COVID-19, the system, the information system were a little bit weak, and we couldn't have all the information on where they are moving and what they need in this pandemic situation. And that is why in the vaccination process, we couldn't have all the information who are leading, where are leading this population and what they need. And that is why I say that some of the important barriers during the pandemic situation is the information system. Before the pandemic situation, we had a huge information system, and now we have a very important information system. But during the pandemic, it was a lack of the information that we couldn't know what they really need. Many of the strategies that were involved in the response of this population were a national response. And if you can see in our inform that we share in this research, you have a huge list of decrees, programs, policies, and plans were developed for the national government. But when we try to know how to have a better implementation of these strategies, there is a low representation in the local situation to try to have a better response. That is a very and it is a very important barrier to implement the strategies that the national government try to develop for the response of this current situation. Some of the facilitators that are presented in our interviews and information that we collected. As I told you before, there are important policy efforts that in some of the situations, these policies and strategies that were implemented were very important in the context of the response of the system of health. But we need to have a better response with the policies because we have many of them in the strategies that weren't formulated, but they need to be implemented in the context of the border realities in this process of migration. The country has many of these strategies, special strategies to enforce detention in women, children, and vulnerable populations. And during COVID, all these strategies were built for the policymakers. And with the international cooperation, we have a really good interaction to try to have a better response. As I told you before, we need to have a better implementation of all these magnificent, interesting formulation of policies and plans. Because in the paper, we have a very interesting strategies that could have a better response of all this population. But in the reality, we need mechanisms to try to have a better implementation of all this process. During the regularization for migrants, there are now special policies, and the Estatuto Temporal de Protección is one of the most important strategy that Colombia were built to try to have a better response of the current situation. But we need to have different strategies according to the capabilities of the system of health to have a better regularization and better information to try to understand what they need, where they are living, and how to have a better response in all these situations. Next slide, please. This is a summarize that I want to try to explain all this information. In the graphic that I showed you, the first part of the response of our Colombian migration process system of health response, because of our push model and many of the displaced population who are living here inside of the country, more of 7 million of people who were displaced of the violence because of the violence here in Colombia. We have different strategies to try to understand what these people need, but we, in our history of migration, we didn't have a specific response for the migrant population. That is why we started during 2015 and 2016 to have different strategies and implementations for Colombian people who were returning for different countries, but from Venezuela specifically. That is why the decree 1978 have a specific information who are coming from Venezuela and what they need, and with all this information and to have a better strategies to include this population to the system of care. We started at our planification and policies and plans in the process of migration. We didn't have anything before. These strategies started in the borders to try to enforce the system of health in the borders, but we need to have a better implementation in all our country to empower the information and to empower the implementation of this current response of the policy response and plans to have a better health system of care for the migrant population. After 2017, we have spectacular information about what these people are, who are coming from Venezuela, who are living in our country, and that is why we have many decrees, resolutions, policies, and plans. And the most important thing is what we have a plan of response of the phenomenon migratorio, the migratory status here in Colombia. The legislation provides many of the information that all the decision maker needs to implement better policies, not only in the border, also in the main cities as Bogota, to receive all this population. But in the current situation of the situation of the pandemic, we have a lack of response, and that is why we need to implement or re-implement a better response of the policies and plan in the international legislation for this response of the migratory status of this population. The international cooperation was very important to this response. We have more of 40 institutions here, not only in the border, and also in Bogota, and in the south border and with Panama, who are trying to have a interaction with our national government and local government, and that is very important for the response of the system of care here in Colombia. And the NGOs have provided mental health services for all the situation that were presented here in our current situation. Colombia needs to have all this implementation to have more interaction between countries, for example, with Ecuador, Peru, and all the countries here in our region, to enforce this implementation, because we as Colombia, a lonely country, we couldn't have all the implementation that were formulated or maker for our institutions, and that is why we need to have a better interaction in our region. And this is information that I wanted to share with you, and thank you so much.
Thank you very much, Andres. Much appreciated. Please, if you have questions, I know there have been some in the open question box, so please add them. Some have already been answered. And now we're going to Luis, who will look at some comparisons and differences amongst the various countries. So to Luis, over to you.
Hi, Paul, and thank you for the opportunity, and also thank you to all my colleagues for this amazing presentation. The next slide, please. If possible, can you do the next 3 clicks? 2 clicks, that's okay. So let's try to compare what all my colleagues already presented. Let's start here with talking about Colombia. As you heard, Colombia has traditionally been a country that has seen significant immigration, with many people moving to places like Venezuela, United States, Spain, and Ecuador. However, starting in 2010, there has been an influx of Colombians Colombians returning to the country due to economic crisis in their destinations countries. In particular, in 2050, the ongoing economic and social crisis in Venezuela led to a wave of migration to Colombia, including both returning Colombians and legal and illegal migration from Venezuela. The peak of this migration from Venezuela to Colombia occurred, as you heard, in 2020, with many people arriving to the country, to the country's largest cities like Bogota, like Cucuta, and Medellin, for example. And the main reasons for the arrival of Venezuelans in Colombia are related to access to healthcare, improving living conditions, of course, and due to the deteriorating social and economic situation in Venezuela. As we saw in the presentation, more than half of migrants in Colombia are irregular, but there is an important process of regulation. During the pandemic, in particular in 2020, Colombia significantly reduced access for migrants in an effort to control the spread of the virus. However, this left many migrants homeless and without access to healthcare, and of course, without access to strategies for testing, treating, and follow-up. As you hear regarding the health systems, you can see in this slide that actually the three of them are fragmented. In particular, in Colombia, the general system is divided into public and private care, as it is in Mexico and Peru. In the case, the population affiliates to the system according to their ability to pay or their condition of poverty and vulnerability. This also applies for migrant population. That's the reason of what this is important. However, affiliation and healthcare from the health system has been fragmented, creating the barriers that you just hear to access healthcare. In the case of migrant populations, one of the main barriers is the regularity situation in the country, which affects access to healthcare for populations in vulnerability. Perhaps this is the main message that I would like to share about Colombia. Due to the conditions of poverty present in many migrants' population, their access to health services is limited to their ability to pay, which can increase and is happening, increasing their vulnerability. For the case of Mexico, there are important similarities. Mexico is a country with significant international migration. The two main components of this migration are the movement of Mexican citizens to the United States and the transit of individuals to Mexico with the intention of entering the United States. Just to have a perspective, as Dr. Yetza just said, Mexico is the second country with the most people living abroad. It's about 20 million people, and most of them lives in the United States, and the migratory corridor between the two countries is actually the largest in the world in terms of volume. So you can imagine the magnitude of the phenomenon that is happening in the country. This is something that occurs in both directions, of course, including emigration from Mexico to the United States and the return from the United States, either voluntarily or through deportation. This is really important because in terms of deportation, these are gradually decreasing in the last decade, from 500,000 in 2009, I believe, to almost 200,000 people recently in 2019. This figure is important because deportees are a vulnerable group as the return is marked by the separation of the social networks, and the entry to Mexico is through different cities, to unfamiliar cities who not sure without sources of support and other health-related risks. Finally, for Peru, Peru also shares some important similarities. Peru has, in particular with Colombia, Peru has received a large number of Venezuelans who have fled the crisis in the country, with a total of 1.2 million Venezuelan residents in June of 2021. This is really interesting because the situation has meant a significant change in the composition of the Peruvian society. This is a phenomenon that well, it's happening in a lot of parts of the world, but like, for example, in Syria and Lebanon, but here it's also happening between Venezuelans who enter Peru. And the transition towards the transit and destination country for migrants, of course, change. On this regards, Peru migratory policy has attracted more Venezuelans through their admission to the country. Nevertheless, this has not translated into real integration into the formal economy and public services of the country. And most of the challenges that we see in this report focuses on this situation. Regarding the health system is also fragmented. The health system in Peru consists of different providers that offer services to different target populations. The Ministry of Health offers services for economically vulnerable population and salud, which you can read here for those with formal jobs. So from these institutions in the Ministry of Health, it is the Ministry of Health that operates the most clinics and health networks in the country. And in general, due to major shortcomings in terms of human resources, infrastructure, budget, and the political situation that you know that it's living right now, there is a significant gap between demand and unmet needs before the influx of migrants. The next slide, please. And you can also do 2 more clicks. Thank you very much. Let's just focus on the access for migrants and regarding the regulation and the barriers. For the case of Colombia, the provision of healthcare to migrant population has been divided in 2 distinct periods, as we see historically. The first period focuses on providing care to those who are returning to their home country after living abroad. And the second period focused on providing care to migrants who have recently arrived in the country, in particular those coming from Venezuela. Since 2015, I believe, the efforts to provide healthcare to this population have been intensified and expanded. However, it should be noted that only regular migrants are able to join the formal healthcare system, as Dr. Andres said. Those who are not part of the system have limited access to care, and the availability of care depends on their ability to pay and their migratory status. This means that they may have difficulties accessing care on a regular basis and may not be able to receive the full range of medical services that they need, in particular during the pandemic. In the case of Mexico, we should focus on 2019, which is the year when the general health law in Mexico has been aimed to establish that all individuals in the country without health insurance have the right to receive health care. The requirements for receiving this care, however, are of course to be in Mexican territory, but of course having not insurance and have a valid form of identification. And this is perhaps, this is actually a big problem because the lack of documents that support legal residence in Mexico makes it impossible to access formal employment, which limits the ability of migrants to obtain healthcare services associated with Social Security. And in practice, many health units ask for the presentation of identity documents or proof of address, which migrants do not have. So just for this detail, that's one of the reasons that migrants are not receiving healthcare. And for Peru, the Peruvian state is committed to guarantee and protecting healthcare access to without distinction, as we saw also in Mexico. And without distinction, including nationality or origin. And this principle is clear in the Constitution. In particular, in 2017, the migration law was published specifying that the Peruvian state recognized the right to health for foreign origins individuals, among other fundamental rights. Regarding the limitation for accessing the healthcare system, Venezuelan migrants living in Peru experience reduced access to healthcare system due to economic, legal, cultural, and informal barriers that we already saw. The COVID-19 pandemic primarily affected these vulnerable groups, despite the territorial openness that we saw in the first slides. And the main areas where Peruvian migrants would need state policies and are regarding the irregular migration status, the economic barriers to access to healthcare services, and those also related to the labor markets. In the next slide, we will continue talking about the responding to the pandemic. For the case of Colombia, the creation of policies by Colombia has been really important, as we already saw. Guidelines for the prevention, detection, and management of COVID-19 cases among the migrants populations has been developed. The aim of these documents is to provide guidance to territorial entities and institutions that support the prevention, the detection, and management of suspected cases and infections caused by the coronavirus among the migrant population. Something interesting in the case of Colombia, is that access to COVID-19 vaccination was made universal. And this is also happening with Mexico. However, given that the scalability of the vaccines in the national territory, migrants' population seems to compete unfairly with to the access of available vaccines in the border area, particularly in the border area. This could not be a problem of policy, but a consequence of the number of the vaccines available in Colombia. And this is also a phenomenon happening in Mexico. And of course, it requires our attention. About Mexico, the operational plan of the Ministry of Health has established its goal of providing comprehensive care for the health of migrants population during the pandemic. However, this strategy seems to focus only in the detection and care of cases with COVID-19. These actions in these documents include the development of census, the identification of people at risk of complications, the implementation of hygiene and physical distance measures, reporting mechanisms for the epidemiological surveillance systems, and for the referral cases. For everything is in this document. However, there are only general recommendations. And this strategy do not consider the necessity element to test, to treat, and follow up any of the cases. One important element, however, is that vaccination, as we said, as I said, is available regardless of the migratory status when vaccines are available. Finally, for Peru, Peru created the special COVID service, which is known as Servicer, having national and foreign health personnel, just expanding the coverage that the health insurance have in order to include for all migrants and all people suspected of having COVID, regardless of the migratory status. However, just for reference, this comprehensive health insurance, it's a public executing agency that provides public health insurance in Mexico, just to have it in mind. However, most of these policies focus on the prevention of transmission and not in the diagnosis and follow-up of cases, just as is happening in Mexico. And in the next slide, please. One of the things that are actually equal regarding the adequacy of health system is that in the three countries, cross-cultural appropriateness is not considered in any of the strategies. Different type of migrants are not considered, and they do not describe strategies to inform how to have access to the services. And finally, they do not mention any strategy to mitigate racism and xenophobia, which in my opinion is the challenge that is very present in the realization of migration policies, not only here but also in any part of the world. Regarding the agents involved, actually is the same for the three. All the local entities related to the government, in particular to the health sector, are involved in the response with the help of civil society organizations and also international NGOs. And these activities are really high for the three on the countries. And in the next slides, I present you just a few conclusions for this work. The first one is during the COVID-19 pandemic, The three countries experienced an increase of mixed migration flows of economic migrants and those displaced by violence, economic crisis, or natural disaster in their countries of origin. If you can do just a couple of more clicks, perhaps would be better for the second one is that these flows represent new challenges for health systems due to the higher proportion of women, children, adolescents, and older adults compared to previous migration flows. You will see these details in the report. The third conclusion is that access to healthcare for migrants was integrated into the health system of all the three countries in different degrees and with different characteristics using the different organizations and financing strategies. So this is present for the three of the countries. The fourth conclusion is that in general, administrative and economic barriers persisted, making migrants' access to healthcare really limited. The fifth conclusion is that the response to the health of migrants during the pandemic focused on the health emergency and the reduction of transmission to COVID-19 with less attention on longer-term sustainable health system response and the right to health of migrants. I believe this is really important. And number 6, and finally, international organizations and international cooperation agencies played and are playing a crucial role in supporting and responding to the needs of migrants during the pandemic. In my opinion, and as a conclusion, the amazing work presented by my colleagues showed that despite differences in the organization and the funding and the governance and other aspects to the health systems in Mexico, Colombia, and Peru, they all share that the characteristics of being fragmented. This means that access to healthcare depends on employment status and the ability to pay, which can result in administrative and economic barriers for migrants. During the pandemic, the COVID-19 pandemic, the health system in the three countries, in Mexico and Peru, focused on the containment of the transmission and addressing the general health emergency, while Colombia's response included the migration policy action to regularize the stay of Venezuelan migrants in the country. Just one important difference. And this illustrates how healthcare migrants is influenced by political and social issues and how it may be necessary to address these problems from a broader global perspective to ensure the right to health for people. That would be all for me, Bob and colleagues. Thank you so much for the opportunity.
Thank you. Thank you very much. If everyone can perhaps turn on their, the panelists, turn on their cameras, please. I'm going to now stop sharing my screen, but just for everyone, hopefully when you signed up, but this report, of course, is online now, and any feedback is more than welcome. I will stop sharing, and now we have our colleagues. Now, we had some questions. They were answered, I think, in the limited time that we have left, because I want to end. I'm going to ask each of you a question, the same question. And I actually think, because I see many people who are online are actually researchers as well and students, is the question for me would be, now that we've done this, what would you do differently in terms of research? Again, if you were to redo this project, what would you do differently? And I'm going to start with Juan. Is the question clear to you, Juan?
The difference in the research of the problem or the difference in the treatment?
I think in the research of the problem, because I think in the last, what Louise described, it's very clear there. I think you've all done such a wonderful job that the similarities and differences amongst the country are clear. But I'd be interested to know, what you would do differently in terms of the research itself. If we could all think back and do something differently, what would you do?
Well, I think this is the first step of one program of research about this topic. And we are in another steps now, studying the health borders for migrants, for example, and we need to combine surveys and qualitative interviews, of some special informants about this. Not only the providers, I think the migrants. We have had the idea of a qualitative study, months ago, but that was, I think, not the moment. But now we have a panoramic view, and we have entered to this second stage, I think.
Great, thank you. Thank you. To Ayitza, any thoughts? What you would do, we could do differently?
I think I'm going to go in the same line as Juan. I think what would have been nice to do was to move beyond this general description and start thinking in hypotheses, a specific hypothesis. I was thinking when Luis was saying that one thing we all share, these three countries share, is the fragmented nature of the system. But at the same time, it is very different, a system based in insurance, in health insurance, which is the Colombian system, as opposed to systems that are not based in insurance in Peru and Mexico. But then we could ask, is that important? Does that make a difference for the access that migrants have? Or is more a matter of resources in the system? Or, I mean, which of these barriers are more important? What is the causal relationship between one thing and the other? So I think I will have like to go into deeper in more specific questions that can move forward the knowledge in this area.
Yeah, thank you. And I mean, the other thing, and we'll go to Andres, is that the policies, they're different, but many had strong policies, but as often in many countries, the implementation of those policies were difficult. And that's just not unique by any means to these three countries. Andres, over to you.
Well, I am agree with my colleagues, but also what I think that we could to try to know more in a more deeply way is the social determinants of health. I think that we can try to understand the social determinants of health in this migrant population, because it's not the same with multiple population that we have been studying with this pandemic situation, but with the social determinants of health that are presented in for example, in the borders, as I told you, is a different situation with the other cities that were involved in the response. But to try to understand the social determinants of health during the pandemic and after the pandemic could be very interesting to try to implement different strategies and different lines of the policies and plans that currently the government are implemented now.
Thank you. Agreed 100%. And Luis, over to you.
Thank you. Actually, I was thinking something similar with Andres. In addition to what Andres just said, I would like to approach not in general, something in general for the country, but perhaps for specific points or places in each of the country, and investigate what would be the poverty traps that they have living in a specific area, because also moving towards different geographic points, the situation is different, the barriers are different. And well, I like this poverty trap concept framework from Mr. Doplo, from the MIT, the Nobel Prize winner. And they actually see beyond all the aspects, the economical, the biosocial aspects that are creating the specific situation in each geographical part. I'm thinking in Mexico, for example, in Chiapas, and for example, in Tijuana. It's different, even that it's Mexico, and the same would be happening in Peru and Colombia.
Thank you. Interesting. Yeah, from my side, this is not what we would do differently, but this is if we had a great deal of money and access to do this, is I would love to do a prospective study of following Venezuelans to all the different countries and over time. But that's been a dream of mine for years, of which I've never been able to succeed, primarily because of funding, of course. Well, I want to end just by saying thank you also to all of 4 of you, but to the many other people that some are listening and some are not, who've participated in this, all of the students who really made this possible for us as well. To Lancet Migration, who sponsored this, and finally, of course, to the IOM Foundation, we're the funders. And I hope everyone has wonderful holidays and a new year. And I hope we will see everyone again, perhaps in January and February, where I will step back and this will be in Spanish. And I hope we'll be able to reach a lot of people. So thank you all.
Thank you all.
Bye.
Thank you.
Bye-bye. Thanks.
Before